I'm Easy Klein. Welcome to Mental Health Update, a program that brings information and hope to people with mental illnesses and to their friends and to their families. The program is brought to you by NAMI, the National Alliance for the Mentally Ill of New York City Metro. We're a self-help group of volunteers, some of whom have mental illness and others who don't. But we work together in education, advocacy, support, and services for people who are mentally ill. It's also brought to you by Fountain House, a clubhouse for people with mental illness in Midtown Manhattan. Mental illnesses such as schizophrenia, bipolar disorder, and major depression are biologically based chemical disorders of the brain. They can affect people's mood, they can affect their behavior, and they can affect their thought processes. Like other biologically based illnesses, such as cancer or diabetes, they're not anyone's fault. Medication can control many of the symptoms, and rehabilitative services, such as those offered at Fountain House, can help people lead fulfilling lives. Call the NAMI Helpline. It's 212-684-3264. We can answer many of your questions, and we can send you copies of our brochures, such as these on schizophrenia and bipolar disorder. And if Spanish is your first language, we can send you copies of some of the same brochures in Spanish as well. If you decide to join us, we'll send you copies of our newsletter, which will tell you about many events in the area, in the metropolitan area, that will focus on issues of mental health, whether it's government or services or whatever. So remember, you're not alone in dealing with the myths and the stigma that sometimes attach to mental illness. NAMI is here for you. Call us, come to our meetings. You can come to our headquarters at 505 8th Avenue on the 11th floor, and we have a great library there with books and magazines and tapes, all related to illness. So you have friends there. Maybe we can help you. Maybe you can help us. So now that you know just a little bit about NAMI, we'll get on with today's show. My guest for today is Dr. Blair Simpson, and she is, and you can correct me any place along the line, a professor of clinical psychiatry at the Columbia School of Medicine and director of the Anxiety Disorders Clinic at New York State Psychiatric Institute. And we're going to talk today about obsessive-compulsive disorder. So it's up to you now, Blair. What is obsessive-compulsive disorder? And are there two different parts to it, or what? How do they relate?
It's a great question. And first, let me just say thank you for having me. It's a real pleasure. I know NAMI does wonderful work, and so I'm really excited to be here and happy to speak with you and to reach out to your audience. Obsessive-compulsive disorder, or OCD is what we call it, is a disorder that's characterized by two things: obsessions and compulsions. And so obviously then you're going to ask me, what's an obsession and what's a compulsion?
You got it.
So an obsession is an intrusive thought, image, or impulse that a person has that generates anxiety or distress. It's intrusive, it's repetitive, it's distressing. And a compulsion is a repetitive act, either something that someone does in the environment or even just something that someone does in their head over and over again, that's usually done in response to an obsession, and it's an attempt by the person to handle or deal with the anxiety or distress that the obsession caused. In our diagnostic system, DSM, the Diagnostic Statistical Manual, you can get a diagnosis of OCD if you have obsessions or compulsions.
You don't have to have them both together?
Not by the diagnostic system, but the vast majority of the people that we see, particularly in clinical practice, have both. And again, usually they're functionally related. Now, while everyone with OCD has obsessions or compulsions, because that's what you have to have the diagnosis, the actual content of the obsessions and the compulsions can vary very widely from person to person. So I want to give you some examples to make it feel a little bit more real, if that's okay.
That's just what we need.
So probably what most people are used to when they think OCD is they think of the person who has intrusive thoughts about contamination or fear of contamination with washing rituals. And that's what I meant by an obsession. Often that fear that something's contaminated can lead to anxiety or distress. And then what the person does is elaborate washing rituals to try to reassure themselves that in fact they're not contaminated, things are clean.
The Lady Macbeth syndrome.
Yes, exactly. So that's one version or one type of content. Another type of content is the person who's got intrusive thoughts about harm, either befalling themselves or someone else or someone that they love. And that's often coupled with checking rituals to make sure that the harm didn't actually happen. But there are many different versions of this. So for example, I worked with a patient who thought that maybe he harmed a stranger on the street as he drove through intersections. And so he would go back round and round the intersection to make sure that someone wasn't in the middle of the intersection hit. When he'd get home from work, he'd listen on the radio to make sure there weren't accidents. So again, that's an example of someone who had intrusive thoughts about harm and had a checking ritual to try to reassure himself. That's, big theme. I'm talking now about big themes. Contamination is one, harm is another. Another big theme that can happen with people with OCD would be intrusive concerns that things are not just right or symmetrical. And this can be someone who sometimes can be a feeling that things aren't just right, or they can walk into a room and see that things are not arranged or ordered. So this can often lead to arranging and ordering rituals or repeating rituals until things feel just right. That's a third thing. Then there are the people who have what we call taboo thoughts. And these are intrusive thoughts or images. Usually they're sexual or religiously themed. And so, for example, this is someone who can have horrible, violent images or intrusive images of sacrilegious images, or they can have sexual images. Again, these are not sexual fantasies that are pleasurable. These are not thoughts they want to have. They're intrusive, so they're obsessions. They generate anxiety and distress. And then people will do rituals, again, to try to reassure themselves that those thoughts they had really are not who they are. And these rituals can be many different things. If it's religious thoughts, people can be praying repetitively over and over again until they're confident that they got it just right. If it's a sexual image that they're horrified by, they might call up a positive image to try to neutralize that bad image. And then the final big theme are people with hoarding concerns. And these are people who, big theme is concerns about if they're going to throw something out or whether they're going to have enough of something. And that can lead to collection of many, many things. Now, those are big themes. Within each of those themes, everybody has their own version of this. And so I'm trying to give you an example of that OCD. People think it's this one thing. It is not. It's obsessions and compulsions, but then the content really varies. And importantly, while there are some people who just are in one theme, many people have multiple themes. And so the symptoms of OCD can be quite varied.
That can make life pretty intolerable for a person to have fears and anxieties about so many things. Is this similar to anxiety?
It's a great question. So right now, so first of all, absolutely yes. I actually think OCD is a diagnosis that people have really sort of overlooked. It is more common than schizophrenia. half the cases start by age 19, a quarter of the cases start by age 14. When people get the symptoms, in general, this is a disorder, sometimes when you have certain symptoms, they can be mild. When you get OCD symptoms, most people have moderate or severe symptoms. And unfortunately, the disorder in many people tends to be chronic, waxing and waning, but persistent. And so if you add that all up, onset in childhood or adolescence, typically chronic course, moderate to severe symptoms if you get it, and not rare, more common than schizophrenia, you can see that this can start early and really get people off track and really have major, major impact on their life. Now, what causes the dysfunction in their life? And so absolutely, yes, one of the things that can cause dysfunction in their life is the anxiety and distress that they feel, because if their symptoms are being triggered all the time and they have a lot of anxiety and stress, that can be a real problem. The symptoms themselves can cause problems. Imagine if you're having intrusive images in your head all day long, and then you're calling up alternative images to neutralize it. How can you pay attention at school? How can you pay attention to your boss? What happens when you're in your head all day long? So even the symptoms themselves, and then it can also cause people to have a lot of avoidance. So people who get triggered, for example, I worked with a person who had terrible contamination fears on the New York City subway, and so couldn't go anywhere near the New York City subway, but didn't own a car, wasn't wealthy enough to have a car. And so, it either meant walking long distances to work or being limited to try to find a job in a walking distance in New York City, and it also meant great dysfunction in his social life, because he couldn't just sort of go out with his friends or go out to see people. So there's many, many impacts. Right now, OCD sits with the anxiety disorders in the DSM-5. So it's been historically considered an anxiety disorder. And it's one of these interesting questions, because some people in the research field, some people wonder, well, is it an anxiety disorder? Is that the best way to describe it?
Well, that's certainly a part of it, from what you say.
Absolutely, it's a part of it. Another way of seeing it is it's a disorder of repetitive thoughts and repetitive behaviors. And so other people, and there's some data to suggest that there's also a connection to disorders like tic disorders, which is repetitive behaviors, or disorders like trichotillomania, which is people who repetitively pull out their hair, or something called body dysmorphic disorder. And so there's a proposal in the next manual, DSM-5, that OCD will come out of anxiety disorders and be grouped with what are called OC and other spectrum disorders. Well, now, that doesn't mean it isn't an anxiety disorder. It just means OCD has some relationship to other disorders as well.
Well, it seems to turn up as part of other, for example, schizophrenia. I remember I used to see a lady on the street who had to turn around in a certain circle, and numbers were part of it, and then she would turn back but stop at a certain number. And it certainly seems to be part of bipolar disorder, too.
Absolutely. And I think this is another part of OCD that not only on its own is it more common than people think, but OCD is more common in schizophrenia and bipolar disorder than people were aware of. So, for example, and I don't mean they're obsessive-compulsive-like symptoms in schizophrenia, but I mean meeting full criteria for OCD, and the studies suggest that around 12% of people with schizophrenia will have meet full criteria at the same time for OCD, and likewise for bipolar disorder. And that's really important, because when you have these two disorders together, now that is a challenge for treatment. The other thing that people sometimes don't know with schizophrenia is that the medications we use for schizophrenia, the antipsychotic medications, in some people with schizophrenia who have this vulnerability to OCD, the antipsychotic medications by themselves, while it can make the schizophrenia better, it can make the OCD symptoms worse.
How do you deal with that in the clinic?
So
halfway.
So let me start by, I think these are very challenging cases to deal with, but I think what's good for me to do is first start with a simpler case, which is someone who has straightforward OCD. And what's very common is not only to have OCD, but also to have other anxiety disorders and depression. Those three things really come together. And I have OCD patients who, when they have episodes of depression, their OCD gets much, much worse. And then when their depression gets better, their OCD might get a little better, but it still doesn't go away. So it's almost like having a life of OCD with then episodes of depression on top of it. You can imagine how awful this is.
Yeah.
To treat OCD, straightforward OCD, there are two treatments. One is medication treatment with a class of medications called serotonin reuptake inhibitors. So those include a medication called clomipramine, which is technically, or nafranil, that's the other name for it. It's an old-fashioned antidepressant, a tricyclic, but its primary action is to inhibit something called the serotonin reuptake inhibitor. And then there are the selective serotonin reuptake inhibitors, the SSRIs, things like fluoxetine, the trade name is Prozac, something like paroxetine, the trade name is Paxil. All of those SSRIs, so clomipramine and all of those SSRIs, all of them work for OCD. All of them, except for the very newest ones, are approved by the Food and Drug Administration. And it's not that the last one isn't approved, it's just the company didn't go through the process to get the approval. They all work. That's the good news. The bad news is, how much do they work? And so,
well, you also said that the thing that makes schizophrenia better might make OCD worse. So it must be very hard to prescribe a medication in that case.
Right. Well, so if we stick with the OCD for a minute, that whole class of medications work for OCD. But what they do is they partially work. So maybe 40 to 60% of people will respond to a trial of an SRI. But often the response is they'll get a 20 to 40% reduction in symptoms. So they're better on average, but they're rarely well. So it's not like what our medication does is take away everybody's symptoms. Now, there's a range. I've seen some people who, when they get on the medication with OCD, do fabulously and really get better, and I see other people for whom the medication doesn't do anything. But on average, what the medication does for people is it reduces people's symptoms. It's sort of like you have a glass of water, and I say to people, it's like the cup becomes half full. You can either say, oh my gosh, look at all those symptoms left, or you can say, well, I'm better. And what medication does is, on average, it drops the symptoms. The good news, though, is there's another treatment for OCD, and it isn't medication-based. It's a very specific cognitive behavioral therapy, and it's of a very particular type. It's called exposure and response prevention. And this is a very effective therapy for OCD symptoms. The downside of it is you have to find a therapist who knows how to do it, and it's very hard work. It's not an easy treatment to do, because what you do is you sit with a patient, you find out everything they fear, all their OCD fears. You make a list of it, from the littlest fear to the worst fear. And then you start right in the middle, and you start exposing the person to their fear. And you expose them to their fear in a very specific way. You don't say, let's go on the subway and then we'll jump off the subway, because that's just what the person does anyway. That's not going to make them better. What you do is for example, someone with a contamination fear, who, for example, might not shake my hand because they'd be afraid of my hand contaminating them. What I might start with is I put a Kleenex in my hand, then I put the Kleenex on the table, and I would ask the person just to start by touching their finger to the Kleenex. They'll feel a lot of anxiety, but if they keep their finger on the Kleenex, that anxiety will come down. We practice that, and then as you see, then we move up the hierarchy. Maybe they hold the whole Kleenex in their hand. Maybe then they hold my hand. Maybe then we actually touch door handles in my office building. Maybe then we build up to going on the subway and putting our hands on the subway pole. That's what we mean by exposure. A gradual, prolonged exposure to the things that generate fear, but in a very structured and very prolonged way until the person's anxiety drops, because that's what we want to teach the brain. What we want to teach their brain is when you touch my hand,
nothing terrible happens.
Exactly, but you might feel anxiety at first, but if you hold on, your anxiety will drop, and so your brain will learn, oh, I don't have to always feel anxiety, because sometimes I do, and so it's about loosening that up, and then exactly, the second part is, and nothing happened. That's the second part. So it's very important that you do those exposures while not doing the ritual. So you have to ask people to do exposures with you, but not to do any of their rituals, which in this case would be washing. So a tough treatment. But when it works, it's life-changing.
How long does it take for somebody to accept the fact that I don't have to wash my hand after I touch the door?
So here's you asked the best key question, right? Which is, if I have someone who's ready to do the treatment, in 17 sessions, we can change their life. But the problem is how to work with people to really get ready to fully do the treatment, not to stay wanting to touch the Kleenex for 17 sessions, but ready to move up that hierarchy, because the faster you move up that hierarchy and get to the top, the soonest there's the crack in the OCD rock and it all crumbles. But unless you get all the way up there, it doesn't happen. And if you're still doing some of your rituals, it doesn't happen. So that's what I mean by it's a very effective treatment, but it's a very tough treatment. Now, we also put the treatments together. So what we find is that for some, we use the medication to sometimes lower the severity of the symptoms, and then we add the psychotherapy on top, because we find some people can do it better when it's combined like that. And the good news is that when you put the two of them together, about half the time, we can really get people well. That's, now, half we can't, but half we can. Now, you asked the question of, so what do you do if you have bipolar disorder, or you have schizophrenia, and you have OCD? And this is where it gets more complicated. So back over to schizophrenia. When we see those two disorders together, we as OCD clinicians, we recommend that you don't use the antipsychotics by themselves. You use a little bit of the serotonin reuptake inhibition medication in addition to try to protect them from the antipsychotic alone making their OCD symptoms worse. Some, I've always wondered, but we've never been funded to do such a study. I've always wondered could you do exposure therapy with people with schizophrenia?
Isn't that what they do when somebody is afraid of airplane rides, for example?
Exactly.
And is that used for OCD now too?
Well, that exposure therapy for airplane rides is, if you will, what we do with OCD, only we not only do the exposure to the fear, we also have to work on not doing the ritual. So it has an added component when you work with OCD.
Well, let's talk just a little minute about, I think there are also non-medication efforts that have been tried. For example, meditation and mindful meditation. Now, I'm not sure what the distinction is between mindfulness and meditation, but apparently that helps people.
Yes. So the two sort of proven treatments with lots of data behind them are the serotonin reuptake inhibitors and the cognitive behavioral therapy using exposure and ritual prevention, like I told you. But sometimes those are very hard for people to do, so you're exactly right. People are also exploring other types of interventions, like meditation, like acceptance and commitment therapy. We often sometimes use cognitive strategies when people are not yet ready to do the treatment or have very fixed beliefs. The thinking in the field is those additional treatments can be very helpful as an adjunct, but it's not what we would use alone. But again, in some cases, not all the studies we don't have as many studies on those alternative things, but they can be very helpful for people in terms of reducing stress and reducing anxiety and improving mood, all of which will help you no matter what is going on.
It can't hurt.
It can't hurt. It can't hurt.
Well, now, are you doing other clinical studies now at the Institute about this?
Yes, so up at the New York State Psychiatric Institute, so there, my OCD research program, it has 2 points. One is for the patients of today. We're trying to figure out how to make current treatments better. So we're looking at how to use therapy and medications in combination. We're looking at novel treatments. We're very excited right now about a new study in children and adolescents using actually an antibiotic called minocycline for reasons that we don't have time to go into. But if you were interested in that, I'd love to come back and tell you all about that. We also have a new study looking to see whether for people on medication, if they do really well in the therapy, is it possible to come off their medication? And that's a brand new study that we've just been funded. We're very excited by that. And finally, we're trying a new technology, transcranial magnetic stimulation, for people with very refractory OCD to see if that helps them. That's the clinical side. That I see for the patients of today. For the patients of tomorrow, what we're trying to do is really figure out what causes OCD, and I mean at the level of the brain. What's going on in the brain that leads people to have obsessions and compulsions? And
Are they doing brain imaging on that?
That's exactly right. We're doing brain imaging. We're partnering with basic scientists who've generated mouse models of mice with repetitive behaviors, and we're trying to understand what causes the behaviors in the first place, with a hope that we could develop even more targeted treatments. As I said, for the half of people that we're not doing, I mean, we do something for them, but we don't do near as much. We don't get them well. That's our goal.
Well, now let me ask you something. Because we're NAMI, excuse me, how can friends and family help on this?
You know, I say first, educate yourself about the disorder so you really understand it, because I think when people understand it, they have a lot of empathy. It's easier to support. The second is support your loved one in their treatment. Don't support the OCD. And that's really important. Support your person. Support your loved one. Don't feed their OCD, and that can be very tricky. I don't hear that radio. Maybe you hear it, but yeah. Okay. Well, that's very helpful for NAMI people to know, and I thank you very much for being on the show. Well, it's a pleasure.
And maybe you will come back again, because it sounds like you have a lot more to say about OCD.
Well, thank you very much for having me.
And I want to thank my crew as well, and Manhattan Neighborhood Network for airing the show.